So, my
I think they're doing
anachronistic
updates on it.
ideas
Should be
like this.
open.
I think we should always consider all of ourselves providers. Providers of what? Well, providers of medical care. It makes no difference what particular duty you have in the apostolate or any organization. You're essentially all providers. But then the question is providing what? Well, you're providing help, providing care.
Is it under?
And it's good to understand that. And in the course of seeing patients, every once in a while you see a patient that can really teach you a great deal, and we saw one of those yesterday morning. But even if they're not as exciting as you think they are as far as teaching attributes, every patient can teach you something. They really can. And so my old way of thinking is you're there to provide something, but probably the most important thing is just listen. Listen to the patient, see what information they're telling you so you can extract good comments that they make about their concern. So that's obtaining a history and asking questions, getting this historical information, listening very patiently, and then of course from that data try to find a way to answer questions that you pose to them, do some sort of testing or exam, and then come up with somewhat of a diagnosis, and then what you consider to be treatment. Yesterday we had a very good patient, and they came, and the story was, this ear is plugged. My ear is plugged. My left ear is plugged. She was about 62, very nice lady, bright. She brought her, I think, had a grandchild with her or something. My left ear is plugged. That's all she said. And I had trouble with my balance. I had trouble with dizziness. And that's what she told us. So the approach is don't look at the ear. That's the worst thing because you don't have any history. Don't even look at that ear. You want to try to get as much information as you can from her. She said about 2 weeks ago on a Tuesday, she's very specific, and that's important. 2 weeks ago on a Tuesday, I got up and I felt horrible. I vomited and I felt terribly dizzy. I didn't do anything all day. I just went to the bathroom, vomited, went to bed, stayed in bed all day, and my ear stayed very full. And we said, you just stayed quiet? Yes, I just couldn't move around because I felt so uncomfortable walking. I just couldn't walk well. So right away we have someone who immediately becomes vertiginous and has ear fullness and stays in bed because they feel so incapacitated. That's significant. Then I like to go through the ritual. Were you having ear pain? Did you have ear drainage? Did you have trouble with your hearing, which they admit they did. Their ear feels full and they say, my ear is full and I don't hear as well. And then the other question was, and they volunteered that, did you have a problem with the vestibular part of the labyrinth? And they said they were truly vertiginous. Well, to be sure that I didn't miss anything, I went through my 3 classifications of vertigo, and she fell into that classification that related to the vestibular part of the ear, because she woke up vertiginous, vomited, went back to bed, stayed in bed, but felt much better that evening, and the ear is full. And then the next day she was better, and so she had a full ear, not the best hearing, but she had a lot of things to do, and that was on a Tuesday, 2 weeks ago. I'm of the belief that if someone tells you they are truly vertiginous, it's such an event in their life, they'll relate it back to a day. So if someone can say, on May 32nd, I was terribly dizzy, and I remember that day very well, you better pay attention to that. They can pick a day that they were incapacitated by rotational phenomena where they felt horrible, incapacitated, being able to walk, and they vomited. Very important to remember that. That really means something to them. And she had earfuls, continued doing things. Last Wednesday, there was earfulness, no pain or drainage. In the interval of time, she called someone, and they said she might have a sinus and ear problem, and they gave her a Z-Pack, which she took. Didn't seem to in any way correct the fullness in her left ear. Last Wednesday, we got all this information by talking to this lady and asking her. Last Wednesday, she went to bed, she woke up Thursday, acutely vertiginous again. Didn't vomit, but felt miserable, and stayed in bed all day, Thursday. And last Friday, the ear remained full, but she got up and did things. There was a little less fullness over the weekend. It was still there Saturday, Sunday. She came to see us on Monday. So that lady is providing a ton of information, and it took us a while to extract that because we had to go back in time and try to sort this out. It took us maybe 15, 20 minutes. But without that information, and if we looked in her ear was absolutely normal to look at. Absolutely normal. But yet it was full. She had fullness in there. Oh, I think I've got something in there. I think I've got congestion. I think I have a sinus problem. And that was the story. But the key feature is this: she remembers the days specifically that she was sick. Tuesday a week ago and last Thursday morning. And then I asked a question of these people, did you feel like you were sick with the flu or anything? Oh no, I was fine, I did this, that on Wednesday. When you went to bed Wednesday, if someone called you on the phone and asked you how you were feeling, what would you have said? I feel fine, I have a little fullness in my ear, but I feel fine. You went to bed, but it was entirely different when you woke up in the morning. Oh, I was sick. I was just spinning and just violently dizzy. Did you vomit? Not this time, but I just stayed quiet. Did you do anything last Thursday? Not a thing. I wouldn't have been able, if I would have gotten a call from one of my grandchildren, I wouldn't have been able to drive the car over to get them. I use the expression, if there was $1 million at Westroads, could you have driven your car to get it? She says, oh no, I couldn't have gone over there. So they're telling you how incapacitated they are. Now, if we hadn't taken the time to go through this diligently to get this history, we would have probably looked in her ear, saw nothing, and probably would have done nothing or inappropriately given her additional antibiotics. So this is a remarkable story. The key features are she remembers the day that this happened, a Tuesday and a Thursday. And the other feature is, to me, which is quite important, is how did you feel the night before you went to bed? I felt fine. So how could someone become acutely vertiginous overnight? Well, it happened the first time Tuesday 2 weeks ago, and again last Thursday. Acutely vertiginous. Feeling going to bed perfect and waking up in the morning really pukey and truly in a sensation of revolving phenomena. Truly revolving disturbance. Well, I'm making a long theatrical presentation here, but that really is a great case of...
What did she eat the night before?
What did she eat the night before? That was the question we asked her. She said, she mentioned some simple things. I don't recall specifically, but it wasn't anything unusual.
No salty food.
But she was acutely vertiginous. And then we started asking questions about her diet, and she has this passion of eating all kinds of salty things, particularly sunflower seeds and things like that. So this is a clear case of endolymphatic hydrops, or Menieres disease. Absolutely classic case. And she's otherwise, when we saw her, she was fine and her ear looked fine. The reason I'm belaboring this is that If we hadn't spent time talking to her, we would have gotten into the trap of just giving her something inappropriate, antibiotics or decongestants or something, and sending her on her way. And would have missed the entire process of what she's having, because now she's had 2 episodes. And that's the nature of Meniere's disease, or hydrops. They have these acute episodes. They feel horrible and recover. Takes them sometimes as much as a day, and then it happens again. Now, the ear fullness is significant because that happened after the first episode. So that indicates that in that 2-week period before the second episode happened, that endolymph system in her left ear is disturbed. Now, I wanted to test her hearing. Obviously, Dr. Drew is gone. We would have had her back today to test her hearing, but he's not here. We would have confirmed that she is truly telling us about poor hearing in her left ear, and it's probably most likely low frequency hearing loss. That's characteristic of this. So what did we do? We spoke to her realistically about the diet, her diet, which she eats good, solid, salty American food. She loves it. She absolutely loves it. And we all do. And sunflower seeds, lots of crackers and things like that. And so you may say, how are you going to treat this? Well, it would have been nice if we would have gotten a hearing test, and we would have confirmed it. Because she's telling us something factual. I don't hear. I think my hearing is off 50%, I think she said, in her ear. What we did is stress the importance of salt, and we tried to use diuretics, which is very debatable. Some people say, oh, you're not going to relieve any fluid in the inner ear with common diuretics, but I still think that it's worth a try. So we started her on generic Lasix yesterday and today, and she's going to call Jean tomorrow, isn't she? And she's going to tell Jean about the fullness. I don't think she'll have another episode of acute hydrops where she's terribly vertiginous again, or may vomit, become incapacitated for 6, 12, 24 hours. So we're going to do that, and the indicator is fullness in her ear. And then she's going to return Tuesday for a hearing test to see what her hearing is like. Hopefully the fullness will diminish, and she'll return for a hearing test in a week from today, and her hearing will be hopefully normal. If it isn't, that's not a very good prognostic indicator. That means that she's had 2 episodes and it's damaged her inner ear, the vestibular part of her inner ear, as well as the cochlear part, which is more important because she wants to hear. She can recover from these attacks of vertigo, but she can't feel comfortable with fullness and diminished hearing of 30, 40, 50%. So that's what that's all we can do for her. This condition is not as uncommon as you think. The mistake that is made is not getting a lot of good historical information from her, and not asking very many questions, looking at her ear and saying, well, there might be some congestion there, and then treating her with something that would be considered inappropriate, just additional antibiotics and things such as that.
Would this be confused with just the benign positional vertigo too?
That's right. See, and that's what we went through, because the student was there. Just to be certain, and I was certain that it wasn't that, we took her to the Dix-Hallpikes, and nothing happened. And the differentiation is there. They have brief episodes of true vertigo, but it lasts a very short 10, 15 seconds, and it's always positional. She got up that first morning. She was frightfully vertiginous and vomited. Her husband had to help her into the bathroom. That's in no way positional, because people with positional vertigo rarely vomit. The only time they might vomit is when you take them through the Dix-Hallpike maneuvers, and you set them off, and they're maybe a little apprehensive to start with. We've had patients like that vomit, but it's rare that they would vomit during the maneuver. It's happened, but it's rare. That would be the second thing in the differential. Positional vertigo, which historically you've sorted out isn't, or high drops. And you might say, wasn't there a third one? Yes, there is a third one called vestibular neuronitis. Those people don't get over their episode of vertigo. They may have the episode of vertigo, violently dizzy, and they stay in bed. Day goes by, they're still dizzy the next day. They stay in bed 2 days, they're still dizzy the third day. And they have nystagmus, and they puke up everything they eat. So that is vestibular neuronitis, which is not common. May go a lifetime and not see but 1 or 2 of those. Those people recover because it is, most people feel a viral disturbance of the vestibular nerve. And they have to be watched so they don't become dehydrated because of the fact that they're not having very much adequate intake of fluids and they're vomiting all the time. And it's not a common problem. It's been 2 or 3 years since we've seen a case of vestibular neuronitis. But
what causes the hearing loss?
the fullness within the
Just like the fluid?
the endolymph system. The endolymph system is throughout the entire cochlea and the semicircular canals, and it's demonstrated by that middle chamber there, the scala media. This runs entirely through the ear, connects up with the saccule, the utricle, and goes all the way through these semicircular canals. And it's a closed system all the way through this whole mechanism. So whenever that's distended, it can affect hearing, and if it's severely distended, it will affect some of the neural activity in the semicircular canals. Well, she started off that way, but there's still residual fluid because your ear feels full. Of these 2 structures, phylogenetically, this is much tougher than this one. Tougher in the sense of how it responds and how it recovers. The vestibular system is a tough old system. The cochlea is relatively new over evolutionary aspects. But her endolymph system in the cochlea is distended. We know it is because she's got fullness in there. And that's what it just feels full because her ability to have sound properly processed is diminished. This endolymph system is distended. The longer it stays distended, the greater the damage. And that's why people with repeated bouts of Menieres disease will all eventually burn out the labyrinth, which is no consequence. You can live without a labyrinth. It'll burn out your cochlear endolymph system, so you'll end up being deaf.
And is that just
It's inevitable. It will happen if it's not treated, or if it progresses, and we still don't know why the progression takes place, although we think it's in part related to sodium intake, but it's never been actually proven that way. It's never been truly proven. All that we know is when these people allow their temporal bones to be evaluated microscopically, you see this remarkable distension of this scala media. It's just distended out. And that's what Menieres did 150 years ago. He examined someone's ear and noted that. He was in France, and that's how his name got attached to this distension. But that's all he knew, is what he found pathologically in that ear. And that's how his name got attached to this entity. But it's a feature that has these subtle aspects of history. And to me, if someone goes to bed fine and wakes up vertiginous in the morning, it might be positional, but that's because they turned and it happened, then it went away. Then it went away, they got up and used the bathroom and came back. If they laid down again and turned, and they had it for about 15 seconds, then it went away. But these people, it doesn't go away. It doesn't go away. Sometimes it's such that they don't even want to move in bed, because if they move, it sets everything off. And of the 2, positional vertigo is much more common than high drops. Probably 9 to 1, 10 to 1, 12 to 1. Much more common. But high drops happens. And the one we saw yesterday morning was fascinating, with all these little features in her history. And once again, not to be repetitious, they can tell you the exact day they were vertiginous of the month and the year. Oh, they were so disturbed physically that it's sort of branded in their memory. That really means a great deal. Something really happened to you on that day. Yes, I remember it was the 7th of June or whatever. Okay, we're going to pay attention to that because that's such a historical nugget. We're not going to just throw it away. It's very, very important.
And pathophysiology-wise, like benign positional vertigo, just remind me again what the difference is and what's happening.
Yeah, in benign positional vertigo, it doesn't show it real well here. In the utricle and the saccule, there's a little God-made layer of gelatin, and on that gelatin are these numerous little microscopic segments of calcium carbonate. They're called otoconia. And if they break loose, they float in the system, not in the endolymph, but in the perilymph, which is the other system around it, which is an open system. And they'll fall down and they'll start touching little neuroepithelial tissue at the bottom of the balance canal. So if they get into that position and those little particles strike that, until those particles move away, you're quite vertiginous for about 10 seconds, then it goes away. It's really a touching of neuroepithelium with these little tiny pebbles of calcium carbonate. And that's why if you do the repositioning maneuvers, you'll get them back up to where they belong, and hopefully they'll stick on the macula again and not come loose. That's a common one. But we took her through just to be sure. It's almost impossible to have both entities the same. Well, you can differentiate that from the history, but that's a common problem. But hydrop is interesting because it's not uncommon. It still happens. It's usually one-sided, but you have to check their hearing to see how much damage is taking place, because these people can go on to have permanent fullness, 10, 15, 20% hearing impairment, and it's very uncomfortable to them because they often have perfect hearing on the other side. Can it be bilateral? Well, over time, Meniere's disease can strike both ears about 20% of the time. Those people are devastated because of the nature of what happens. And the attacks are totally unpredictable. Once again, she went to bed fine on Wednesday, woke up on Thursday, couldn't drive her car to the West Coast to collect $1 million. She couldn't have, it would have been impossible to do that. So I'm going to go to the West Coast and collect the money.